morning, everyone, and it's really an honor to share space with such learned speakers. I'm not talking exactly on cataract, but very close cousin of cataract, the Phakic IOL, which is done to get rid of our glasses.
Doel, can you make it full screen?
Yeah.
It is okay.
Yes.
That's
So there is a spectrum of refractive surgery. We have the cornea-based refractive surgery, the lenticular-based refractive surgery, and of course the combined. And the Phakic IOL falls under the lenticular-based refractive surgeries. So in a history of Phakic IOL, the first model was made by Fyodorov in 1980s in Russia, and the first implant was done as late as 1993. Now, there are different types of Phakic IOLs, the anterior chamber, the iris-supported Phakic IOLs, but the ones that I'm talking about are the plate lenses that fit between the iris and the crystalline lens, just in that space. Now, what are the advantages of these posterior chamber IOLs and why didn't the others be so successful? To begin with, they're behind the iris, which means that they're far away from the corneal endothelium. This provides excellent cosmosis, and it has a greater effective optical zone. Also, these are sulcus located, so they're much more stable. They can be removed easily, no matter what the timing, how many years later, you can remove them very simply. And there is no tissue damage, no iris damage, and they don't alter the shape or they remove the tissue as is done in case of a LASIK. Now, there are different varieties of Phakic IOLs in the market. The ICL is the pioneer, and they are the oldest one and were the most popular ones. There is, of course, the IPCL from the Care Group basket. There is Upper Swami has come up with the RIL, and now you have the latest one, that is the Biotech. Now, my personal experience has been with the ICL from the Star Group. I've done very few with the RIL from Upper, and I have also used the Care Group IPCL. Of the three, I am most comfortable with the IPCL, and over the last 5 years, I have switched over completely to using the IPCL. Now, the characteristic of the IPCL, the incision is 2.8 millimeters. It is customized according to the shape and size of the eye. The correction range is huge, from plus 15 diopters to minus 30 diopters. I have done up till minus 25 diopters. Cylinder is up to 8 diopters. And the material that is used is acrylic material, and there is no porcine polymer, unlike ICL. Criteria are again the usual criteria that you have for refractive surgery: age above 18, stability for at least a year, and when do you use it? Now, there are some surgeons who do IPCL or Phakic IOL in whatever may be the refractive status of the eye. But there are others, and I am one of them, who goes for a Phakic IOL only when the patient is unsuitable for a LASIK. Also, the anterior chamber depth has to be at least 2.8 millimeters, and the endothelial cell count has to be more than 2000 cells per cubic millimeter. Now, what are the contraindications? There are a whole lot of contraindications, but the most important thing that we look at is the anterior chamber depth, which is also one of the reasons why there are very few hypermetropic patients who can actually undergo Phakic IOL, because as we know, in hypermetropia, the AC tends to be shallow, and we rarely get a patient who has an anterior chamber depth of more than 2.8 millimeters. The power range, as I mentioned earlier, was minus 0.5 to minus 30, and astigmatism up till 8. They have also come up with a presbyopic IPCL. As such, I have no experience with the presbyopic IPCL. Preoperative assessment, you do the refraction. I do all my patients, I do a cycloplegic refraction of all my patients. The anterior posterior segment examination, anterior chamber depth, again, that is one of the most important things. The intraocular pressure, and the other very important thing that you have to take measurement of is the white to white. Now, the anterior chamber depth, we You can do it with the A scan. Now, depending on your machine, whether you take the depth from the external surface of the cornea or the internal surface of the cornea. If you're taking it from the internal surface of the cornea, that gives you your anterior chamber depth as it is right from the machine, you get it. If you are taking from the external surface of the cornea to the anterior surface of the lens, in that case, you have to deduct the pachymetry. And the internal anterior chamber depth should not be less than 2.8 millimeters. Now, there's something called the vault. This is measured after you have put the phakic IOL. So the vault is basically, by definition, the distance between the anterior surface of your natural physiological lens and the posterior surface of the phakic IOL. And it plays a very important role, as we shall see post-operatively, which is why the white-to-white measurement that is taken pre-operatively is very important, because that will determine your vault. The white-to-white measurement, you can take it with an OpScan, with an UBM or the digital caliper. The most accurate is the digital caliper, but you should always tally it with your other machines. If the white-to-white range is too short, then your IPCL also will be short, which will then lead to a vault that will be less than normal. And this will have a chance of creating an anterior subcapsular cataract. On the other hand, if your white-to-white is inaccurate, it's taken more than what it actually is, you'll have an IPCL that's large, that will exceed the normal range of the lens vault. This will lead to angle crowding and thus cause angle closure glaucoma. So the ideal vault should be in the range of 0.250 millimeters to 0.750 millimeters. Now, this is the way you take the white-to-white measurement. You can take it with a manual caliper, but ideally it's done with a digital caliper. Now, the IPCL implantation, the actual surgery itself, minimum dilatation, you don't want it to be too dilated because you have to tuck it under the iris, but there should be a dilatation of 8 millimeters. Anesthesia, now it is usually said to do it under topical anesthesia, but I myself do it under peribulbar anesthesia because I am not very good at vocal anesthesia on the table, and I really like to stay cool and keep my patient cool. The draping and everything else is just like cataract. Before you take the patient up on the table, the marking, the axis marking is done. Now, the beauty of this care group IPCL is that the toricity is incorporated into the lens. So you only need to mark the 0 and 180 degrees, and you place the lens exactly at 0, 180 degrees. Unlike other lenses, you do not have to, dial the lens 10 degrees this way or that way and, take another marking for the toricity. The toricity is incorporated into the lens, place it 0, 180 degrees, and you're done. IPCL is injected through the injectors, and if you look at the IPCL, you'll see there are some, first and foremost, there are 6 foot plates, 3 on each side. Now, these foot plates, they increase the stability of the lens. This is the newer version. The older version had only 2 foot plates and was a little unstable. But this version, which is called the version 2, has 3 foot plates on either side. So the stability is much more. They have these holes which allow the pressure to be equal on both sides and also allow the visco to come up. The newer version has the version 2 has come up with a central hole. So now we don't need to do a PI prior to surgery because you can take out the visco through the central hole. And there are these 2 extra holes at the junction of the aptic and the haptic. And these 2 holes determine your alignment of the lens. The alignment is very simple. The surgeon always sits at the temporal side of the patient. If you're doing surgery in the right eye of the patient, the 2 holes have to be on your left-hand side or the superior quadrant of the eye. And vice versa, if you're operating on the left eye, the 2 holes have to be on the right-hand side of the surgeon or the superior quadrant of the eye. And if the vault is upwards, you cannot go wrong. Your lens will be perfectly placed. So again, open the cartridge, fill the injector with saline and with your visco. Open the IPCL container, lift the IPCL very gently with McPherson forceps. It is a very fragile lens. You don't want to damage it. Check the orientation of the IPCL, very important. I usually place it on my palm to check the orientation and then place it on the cartridge and put the cartridge into the injector. The folding of the lens is very, very simple. Another reason why I prefer the IPCL to the ICL. Surgical technique, you do paracentesis, put viscoelastic. I have the video, so I think I'll proceed with that. As you can see, the marking has already been done here. And I like to again check the marking and make it a little darker, because sometimes with all the cleaning and everything, the marking becomes a little light. So I'm checking the marking, they're almost perfectly done. And that is my paracentesis. This is one of my very, very early cases. And believe me, during this stage, I used to be really a little jittery while going here, because despite the fact that you have a good deep anterior chamber, it's a myopic patient, there is still that constant fear that you have, the virgin lens below and the absolutely pristine cornea above, and you just have so much space to do your work. So making the clear corneal incision. And the amount of visco that you put in should just be adequate. Don't put too much of visco. Ideally, it is said you should put in visco till you see the very last thread of the visco. Do not let the threads, sort of disappear. Be there till you can see the visco. This is the lens. Lift it up very gently with your McPherson. Try not to touch the optical area. Check for the orientation. I always put it in the palm of my hand and check for the orientation. This is the injector. See that it is inside the grooves, that no part of it is above, because if you close the injector and any part of it gets stuck, it's stuck there. It's, as I said, it's a very fragile lens. So during the movement, it might just crack. And when you're closing the injector, listen for the click sound. If there is a distinct click sound, that means no part of the lens is caught there, it's in the groove. After I put it into the injector, I always check to see that the movement is free, that it's not stuck anywhere. So on both sides, I check to see the smooth movement. And once I'm sure about that, again, as you can see, I'm putting in some visco, but as I said, this was my early cases. You really, really do not need to put in so much of visco. And here I'm going in and very slowly pushing in the lens. Now, the technique of pushing in the lens is that you do not push it in one go. You push, you stop, you push, you stop. This sort of helps the lens to unfold very slowly, and you watch for the unfolding. And at any stage, if you suspect that your lens is going to topple over or it's turning, you can just take it out. It's very simple to take it out and then reinsert it again. So this is the technique of doing it. Push and stop, watch for the lens to unfold. And as you can see, the two holes, this is the left, this is the two holes that were there. It is now on the right-hand side on the superior quadrant. And I'm going in with the lens tucker and very gently pushing it in. Now, what has happened in this case is that, it's the iris has sort of, it's not exactly as much dilated as I would have liked it. A little more dilatation would have helped me in tucking the lenses quicker. But so I'm having a bit of a struggle here, but I'm able to do it quite comfortably. And once the haptics are tucked in, you just have to ensure that it is aligned. There are 3 markings on the optic haptic junction that has to be aligned with the markings that you have made previously. And now one very important step, and that is to take out all the viscoelastic. You have to be very sure that every bit of viscoelastic has been taken out. Otherwise, this is going to cause a rise in pressure. Unlike in cataract, sometimes a little bit of viscoelastic is left behind. It doesn't cause such a lot of damage. But here you have to take out. So I watch for the last thread of viscoelastic to come out, and then I still wait and do a little bit more of aspiration. And then just like cataract case, you just close your wounds and that's it. So a refractive surgery is a very, very satisfying surgery. And as one of my patients has said that, it's a routine surgery for a refractive surgeon, but it is a life-changing experience for a person who has been wearing glasses like -13, -15, -25 for most of her life. And then to be able to see without those thick glasses in front of her is really, really life-changing. Thank you so much for a patient hearing.
Thank you, Dr.